Symposium, where we're going to cover current and future guidelines for CLL and follicular lymphoma. The format of this evening is that first we're going to start with CLL, and then we're going to move over to the more important disease with follicular lymphoma later. We've got an excellent faculty for you tonight, and I have the pleasure of just being able to have a few introductory slides and don't have to give a talk, which is even better. So this, in terms of disclosures, the Satellite Symposium is sponsored by Mundipharma Oncology. There was no influence taken on the content of the presentation by the sponsors, and I can promise you that was the case because we were all making our slides this afternoon, much to Chantal's horror. But the presentations contain recent study results, and some of the data shown are going to be based on substances, combinations or other therapeutic indications that are not approved in Switzerland or in other territories. The language gets more and more and more difficult every single time we do this, isn't it? For more details regarding the approval indications at the administration of medicinal products, please refer to the corresponding information for professionals in the area in which you practice. So in terms of thinking about CLL, of course, for 50 years, CLL was Sleepy Valley. We had one drug, not much we could do about it. It was watch and wait, and then chlorambucil, and then a bit more chlorambucil. But the last year has been an extremely exciting time in terms of the unprecedented number of new agents that we have available. So in addition to our standard regimens like BR and FCR and the chlorambucil that we had, of course, for a long time, within the last year, we've seen the approval of obinutuzumab and ofatumumab for the treatment of previously untreated CLL, and of course, ibrutinib and idelalisib plus rituximab for not only the treatment of previously treated CLL, but for those with 17p deletions and mutations who are previously untreated. Clearly, this number of agents greatly increase the options that we have to treat the disease. And whereas they haven't necessarily all been incorporated into all of our guidelines yet, this gives us the opportunity to start to think about designing and thinking about optimal therapy approaches for optimal patients. And I think that's going to be a recurring theme of what we're going to be hearing this evening. As we all know, FCR remains the standard and the gold standard of treatment for patients with CLL on the basis of the overall survival advantage demonstrated in the German CLL study group 8 study, demonstrating, as you see here, a clear survival advantage for the use of chemoimmunotherapy with FCR. And of course, this very exciting data was the first frontline clinical trial in which we had ever seen a survival advantage. It's a recurring theme also we've seen with a number of the new agents that we are seeing survival for the better agent over the less good agent, again suggesting that the old approach we had of you start gently with treatment and then you think escalating the therapy is not the approach we should potentially be having. But of course, we have to be very well aware, and everyone in the room is that the CLL-8 trial treated those patients who were young enough and fit enough to receive combination purine analog-based therapies, and that does not apply to the vast majority of our patients with CLL. The median age of CLL at diagnosis is 71 years. 68% of patients are aged greater than 65, and the vast majority of these patients have some degree of comorbidity. And what that means is that, until relatively recently, we were being asked to make treatment decisions for all of our patients on the basis of clinical trials like CLL-8 that were only on selected numbers of patients. What we now have is we can start thinking about our patient spectrum of we have patients in whom are clearly going to be fit for FCR, and on the other hand, of course, we have patients who are only fit for palliative care. And then we can start thinking about ways in which we can, with frontline therapy regimens, think about where particular regimens might fit, where they'll fit in frontline and relapse, and we can start thinking about where our patient stands and where we can design the right treatment for that particular patient. So, in addition to BRNF, CR, and chlorambucil that we've had in the past, a large number of new agents have been approved. Obinutuzumab, ofatumumab, ibrutinib plus idelalisib and rituximab. So I do believe there's a perfect opportunity to tailor the treatment approaches to the needs of the individual patients based upon their fitness, their ability to withstand conventional chemotherapy approaches, and of course the presence or absence of resistance and mutations. And at the moment, we're doing this on the basis of P53 deletions and mutations and 17P deletions, but there's a lot of emerging data about other mutations that we may incorporate into future algorithms in terms of whether we use antibodies or not. There are very specific side effect profiles with different agents, different abilities to be able to be used with other non-chemotherapy drugs. Use of anticoagulants, the use of other therapies may well impact upon why we think about it. And clearly what we are excited by in CLL is that a new approach to management is on the horizon, except that I would say that it's already here. So with that said, I told you I was going to be very brief.